name's Katharine and I'm one of the head and neck consultants that's currently working within the Liverpool University Hospital NHS Trust. The ideal time to see somebody in their journey, I think, is as soon as there's a concern. So high-risk patients for head and neck cancer are still patients who are heavy smokers, heavy drinkers. There's still a proportion of that. Obviously, over time, that does decrease as patients do tend to have been reducing the amount of smoking and drinking. However, that will still be an area which is high risk for us. We also know there's good evidence to suggest that patients from higher areas of deprivation and lower socioeconomic groups have a higher risk of having a head and neck cancer. They also tend to be the group of patients that present late, and it's not uncommon for them to turn up to the emergency department with acute airway compromise and acute difficulty in swallowing. And obviously that's the group of patients we want to try and reach earlier, when potentially there were more treatment options available rather than it being an emergency. So currently for the rapid access diagnostics, we will get our referrals through from our primary care clinicians. We will then see them in our rapid access clinics and then organise necessary investigations from that point moving forward. So typically most primary care clinicians will have an online form which is filled in and then will get sent through to cancer services within the different trusts. There are a number of different forms and the aim moving forward is to unify this into one so that it makes it easier for cancer services coming through in the secondary care. However, if there's any concerns about which form to fill in and the access to that, then the best protocol would either be one of the other GP partners or the private practice manager. So the key bits of information we need is definitely risk factors. So smoking and alcohol is incredibly important for us. And really it's these combination of symptoms. So although one tick will get the patient in if it fulfills the right box, then actually what we want to do, we don't want to make it an arduous process of referring a patient in, but there's real benefit in putting in as many symptoms as the patient has on the form, because it really helps us triage them into the best clinic to be seen. So it's really those combination of symptoms, because if somebody has a neck lump but they've also got weight loss, difficulty eating or drinking and ear pain as well, and they're a smoker and a drinker, that rings all of the alarm bells that there could be something going on. So really the more information that we can have on the form about these differing symptoms is really important. By doing that, hopefully patients will come through earlier, and the earlier a patient comes through, the more treatment options are available to them. The earlier the cancer is caught, then it means that potentially the different treatment modalities, they won't need to have as many, they won't need to have as severe and as potentially life-changing surgery, and that the treatment would still be an option for cure, because we know that patients who present late, either with airway compromise, difficulty swallowing, then the outcome for those patients will be worse, and the likelihood of curing those patients is far less than if they had presented sooner. And that is our aim and hope. The benefits for patients coming through a rapid access clinic are huge. They get to be seen very promptly by clinicians. They'll have thorough examinations to complement the examination that will have already happened in primary care. They will then have, and the hope is that they will then have same-day investigations in the form of an ultrasound scan if needed, and also have access to a certain number of scans in the form of MRI and CT. Obviously, if there's a high-risk patient and we can do that ultrasound scan there on the day and we can actually reassure them that there isn't anything going on, then they can go home that day knowing that they haven't got a serious condition. That has a dramatic improvement on patients' well-being and anxiety levels. On the opposite side of that, we can also then, on the same day, having seen them, can then start to have that explanation about what might be going on, what our concerns are, and we can start that conversation with the patient that they will be needing to have further investigations and moving through the pathway. I think having a number of discrete conversations with patients is good, because we know that patients won't take all of the information in on one sitting. So I think if we have these initial investigations on day one, then we can at least start to try and lessen that shock as they move down the pathway.